Good afternoon. Happy Wednesday, everyone. I am very excited to be here. You will be watching us live over the Unite for Her Facebook page. I'll give you a couple minutes to hop on and watch, but we are streaming live today for our monthly Ask the Experts series. So my name is Erin Pellegrin, Senior Nutrition Manager with Unite for Her. If you're unfamiliar with our Ask the Experts series, this is our time to share all of your questions with experts in the field, having to do with all topics related to breast cancer, ovarian cancer, general health, even other topics. We've done COVID in the past. So today we are very lucky to have back one of our fabulous experts in lymphedema. So our speaker today, she was with us for our speaker series, which we hosted earlier in August, and we got such resounding applause from her information and education and questions. We thought we have to have her back to continue to answer our questions. So we're happy everyone is here. So for today, if you weren't able to see Nipa with our speaker series, I would like to welcome her and share a little bit about our esteemed guest before I bring her in. So just to share a little bit about Nipa, she is the CEO of Bucks Cancer Rehab, and a little bit of her background because she has worked as in occupational therapy and lymphedema for many, many years. And I think when we find someone like her with such expertise and such a wealth of knowledge, that it's always great to share a little bit about her background. So Nipa graduated from Bombay University with a bachelor's degree in occupational therapy in 1994, migrating to the United States in 1996, and she worked in a variety of settings from pediatrics to geriatrics in New Jersey. She passed her boards in 1997, and she got her lymphedema therapist certification from the Close Norton Institute in 2003, so a ton of experience there. She developed the breast cancer rehab program in Princeton Hospital in 2007. And in 2019, she received her certification in oncology rehab through the PORI Institute in Colorado. She has truly devoted her career to cancer rehabilitation and helping everyone get through their journey. So without further ado, I would love to bring in Nipa. Hello, how are you?
Very good, Erin. Thanks for having me.
You are welcome. As I said, I think I shared so many times the positive feedback we got from your speaker series talk earlier this month that I thought we have to have you back just to answer some more questions. There are so many that didn't have a chance to attend that passed along some questions. So I think it's always really worthwhile to just to provide some more information, and streaming it live on Facebook so everyone can learn is always a great avenue. So we appreciate your time again.
Absolutely. Anytime. I'm ready to help.
Perfect. Thank you so much. And I want to remind our audience, so for those of you that are watching on Facebook, you are able to share questions in the chat. So I am watching live as you're moving through. So as Nipa goes through and explains and answers our questions, if there's something of interest to you, feel free to put it in the chat and I will pass it along to her. So let's get started, Nipa, with general. Talk to us a little bit about what lymphedema is.
So lymphedema is this accumulation. First, let's start with about the lymphatic system, the anatomy of the lymphatic system. So we all have a circulatory system, a neurological system. In addition to that, we also have something called as the lymphatic system in our bodies. The lymphatic system was actually vastly described by Leonardo da Vinci way back in the 15th century. Yes, and when you do visit the museum in Paris, the Louvre, you actually get to see his diagrams then, which were done in the 16th century about the lymphatic system.
Wow.
We didn't start learning about the lymphatic system, though, until the 18th century. And our doctors, in this day and age, we started talking more about the lymphatic system in the late 80s, early 90s.
Okay.
So it is like, talking about the lymphatic system, it is primarily the system that sort of drains and removes debris from the human body. Along with that, the fluid that travels in it are the T cells, your B cells, and unfortunately also the cancer cells. It's one of the first portals for the cancer cells to move.
Okay.
So what happens when, since we are talking about more of the cancer field, I'm going to talk about lymphedema related to cancer, because there are lymphedemas that are related to other issues as well. So in the cancer field, what happens is oftentimes the nodes, we have about 1,800 to 1,000 lymph nodes that are
Wow.
filtering stations inside our body. Modern research also shows us that the glial cells in our brains, the term glioblastoma actually comes from the glial cells. The glial cells also run a parallel lymphatic system called as the glymphatic system. And that is the reason why, understanding how lymphedema actually affects us is very, very important.
Yeah.
So in a typical practice after any kind of cancer surgery, and oftentimes even in the liquid cancers, like you do see lymph nodes enlarged in the body. So
Yeah.
the lymph nodes are trying to drain away and remove these cancer cells.
Okay.
When the doctor goes in after a surgery and tries and remove some of the lymph nodes, because doctors nowadays know that the lymphatic system is where the cancer will move from. So in order to prevent the cancer from moving, they do remove the lymphatic nodes. And
Okay.
when nodes are removed, you want to remember the vessels that connect to these nodes. So there is a node in between, and there are vessels that connect to the node, which supply to the node basically. So the vessels are just spilling fluid in the area called as interstitium, which is like a space between. It's basically a space where everything is located.
Yeah.
All your veins, arteries, everything is located in this space. But then this fluid sort of oozes out. It has nowhere to go because
Okay.
the lymph node has been removed that was ready to drain it.
Okay.
So that is when you start developing a volume increase in the arm. And there are new methods of actually assessing that very little volume increase also. Devices like the bioimpedance device will actually assess lymphedema before it actually becomes lymphedema.
Wow.
So yeah, I mean, there are these devices. Some hospitals carry them. Some of the major cancer hospitals actually have them. Most local hospitals do not have the bioimpedance device.
I was going to say,
Um,
if with those sort of devices, if a person is concerned about potentially developing lymphedema, is that something they could
yes,
ask someone like
yes.
you or a provider? Oh, do you have this device? I want to check my risk.
Correct.
Oh,
So it's not just the risk. The bioimpedance device works on a mechanism almost like assessing a volume increase in a limb versus the other limb, or volume increase in a certain part of the body.
okay.
There are leads that are attached basically, and then it's like a small device where you get a reading.
Yeah.
That's a bioimpedance device, and it's done in the early stages of if the doctor is really concerned that the person would develop lymphedema.
Yeah.
Again, those devices are extremely expensive, and they are done basically in our area. Basically, I would say UPenn has it.
Okay.
Fox Chase has that device, and
Okay.
no other hospitals really have that device, because just assessing that part is also very, very expensive.
Okay. Can you, so
Um,
we had a question. Someone is asking, could you please say the name of the device again? I think she
right.
wants to ask.
It's called a bioimpedance device.
Okay. Bioimpedance device. Perfect.
And
Okay.
you can research that online also. I mean, there's plenty of information on the bioimpedance device online.
Okay. Perfect.
There is a new company that also came on. It's called the Sozo. Sozo is very similar. SOZO
Okay.
is very similar to the bioimpedance device, and some of the hospitals again have the Sozo. Most hospitals, like I said, if it's not a hospital that is catering just to cancer,
Yeah.
most of the hospitals will not have it.
Okay.
Um,
Okay.
But yeah, I mean, like for the early stages, that is one of the most important devices to assess whether
Okay.
a person. So it gives us a good assessment as to whether the person may stand a chance of developing lymphedema, and
Got it.
if we can actually treat the lymphedema right there and then.
Ah, interesting. Okay. So in figuring or determining if a person is at risk for developing lymphedema, what are those factors or variables that puts a person at risk for developing it?
Okay, one of the biggest factors is a surgical removal of lymph nodes.
Okay.
Basically, like depending on the type of surgery, and now we are addressing more of like breast cancer or ovarian cancer. So in the axilla, okay, so if a person had lumpectomy,
Hmm.
the doctor goes in and puts in a dye to see, and this I'm talking from experience because I've actually attended some of the surgeries. So the doctor will go and put in a dye. It's a blue dye that eventually comes out of the pee.
Okay.
Um, yeah, I mean these are facts
It
that
goes
like
in, it goes out. Yeah.
it just goes out of your body. But
Yep.
the first lymph node that uptakes that dye is removed. That is called sentinel lymph node biopsy.
Okay.
Just doing one lymph node does not cause lymphedema. It may cause localized swelling, post-surgical swelling, but it does not cause lymphedema.
Okay.
So once that basically that node goes to pathology, the doctor waits for a phone call from pathology, which takes about 15 to 20 minutes. And then the pathologist calls whether that was a positive node or a negative node. If it was a positive node, the doctor has to go in and remove the entire lymph pad. So that is called axillary lymph node dissection.
Okay.
That is the first level of lymph nodes that are removed. So we
Okay.
have several levels, right in the armpit, there's level 1, going internally more, there's level 2, and then going more closer to the lungs, there's level 3.
Okay.
So each level of lymph nodes, each pad basically has about 13 to 18 lymph nodes in there, embedded in there.
Okay.
So that when that entire pad is actually removed, that puts a person. There was a surgery I had attended, and the doctor just simply said to me, "This is going to be your patient." Unfortunately, because they
Wow.
had to go in and remove the entire pad of lymph
Wow.
nodes. So
Okay.
that I just basically know that that person gradually would develop lymphedema.
Okay.
But the way I would treat that person is address it as soon as possible. I don't
Yeah.
want to wait with that person.
Okay.
Address it, get the person in, start working on lymphedema management techniques, and that's how I would deal with it, and not lead, and that wouldn't lead that person to the big arms that you see on the internet.
Yeah. Okay. Okay. So, and is that the way to go? If I were the patient and I know that this procedure that I had, puts me at risk, the best thing to do is just get in before things develop. Is that
That's
really the
correct.
best
That is
approach?
correct. And fortunately, since 2003, when I graduated to up to now, doctors are very, very good at sending people to therapy. Because you want to also remember, the American Cancer Association has actually set certain guidelines, when to send people for rehab, and sending people for rehab after a surgery like this is quite pertinent, actually.
Yeah, that's good to know. That's really wonderful to know. Can you talk a little bit from our series earlier this month? You had mentioned stages of lymphedema, and I think something that shocked me was learning that there is some lymphedema that is reversible or potentially
Yep, yep.
reversible.
Mhm.
So could you speak a little bit about that?
So we're talking about stage 0 to stage 1 lymphedema.
Okay.
That is fairly reversible because we can actually treat it, have a compression sleeve, and follow up with the patient every 6 months. And most of the times, I have seen quite a lot of stability in the lymphedema, or what you start noticing is that the lymphedema actually reverses, new lymphatics are formed, and I've had patients I followed for 6-7 years. Year 1 was compression garments and lymphedema treatment. Year 6, zero, nothing
Wow.
needed. So those things do happen. The lymphatics do grow. Our job as a therapist is to actually channel the lymph into the good lymph nodes. And that channeling actually initiates new lymphatic growth.
Wow, that's great. Okay,
Yeah,
so
so
those
that
early stages, yeah.
yeah, sorry, go ahead.
No, that's okay. Go ahead.
So the reversible lymphedema is what we call stage 0 to 1. Stage 2 lymphedema is when we actually see like a girth of beyond like 6 to 8% in volume increase. That's when it's like at stage 2. Stage 3, I would say in this day and age, I barely see it, because that's when lobules develop, and like, there's hard like fibrotic tissue that develops, and nobody nowadays reaches that stage really. So
Okay.
most of my patients, I would say at this point of time, 0 to 2, at the most 2 stage
Okay.
lymphedema. So we
Okay.
are in a good state.
Good. Yeah, that's really good to know.
There's
I
a
love that.
question here from Susan.
Yeah.
Something. Thank you so much for
Yeah,
that.
she asked, which I think you pointed out, asking why PTOT lymphedema eval is not part of the treatment plan. Is that the case for all,
Yeah.
all hospitals? Is that part of the general procedure?
I have to say no. I don't know how Susan, you or Suzanne, how this has gone through. I mean, like, it has fallen. Sounds like it has fallen through the cracks for 14 months. Nobody goes away with that nowadays, because doctors, like I said, if they are certified under those banners of what is it called? Like, if it is a nationally credited hospital for breast cancer, or a nationally credited hospital for ovarian cancer, then by their standards, they have to write a script for physical and occupational therapy post-surgically, even pre-surgically, actually. So I'm surprised, Susan, that this has happened to you, unfortunately. But at the same time, it's not too late. Let's put it that way. We can still treat it.
That's great.
Yeah.
That's great. And I guess that just sort of speaks to really being your own advocate, for doing the
That's right.
reading and really just asking those questions and pressing and with areas like this sort of specialty, if you know that there is a risk down the line, sort of taking those steps and asking about it. Now, in terms of lymphedema development, is it something that a patient may notice within the first year? Is there a risk for a person developing lymphedema down the line? What's the time frame like for that?
So about 90% of the patients who are at risk will develop it within the year.
Okay.
And about 10% of the patients, and those are the patients who we know are the younger patients. I mean, I'm not trying to classify people here, but people who are more active, even pre-surgically, do stand a lower risk of developing lymphedema. Like, I've had people who are bicyclers, people who are they play tennis regularly. The incidence of developing lymphedema, despite the fact that they might have had axillary node dissection, is much lower than people who do stationary jobs. People who do they're basically very minimal exercise in their life. They've had very minimal exercise in their life.
Okay.
So needless to say, exercise does play a huge role in movement of lymphedema.
Okay. Okay. Well, and to that point, Nipa, so one of the questions that one of our community members submitted was, are there certain arm exercises that a person can do to prevent lymphedema?
So I'm going to rephrase that question, because the prevention part is mostly when you've had just a sentinel node biopsy, or it's also basically we are watching a person with axillary node dissection, or just lymph node dissection per se. We want to watch and keep a close watch and catch that before it gets worse. With most of the patients, yes, there is a set of exercises that we do prescribe, that they are supposed to do like 2 weeks or a week after surgery, depending on the hospital they are at. Okay. And that is called like it's part of their pre-surgical packet. A lot of the times, I do have to say, I'm more than 100% of the times, people do forget, because They are so overwhelmed with information.
Yeah.
So the best way of actually dealing with this is, like, go to your therapist like second week after your surgery. You have your appointment with your surgeon, get a script for physical occupational therapy, and go to your therapist, like, get their exercises again. But there is a set of exercises. There's a set of, like, I think 7 or 8 exercises that we typically give patients, and they're basically just range of motion exercises to prevent any kind of seromas. So the exercises are basically given to prevent seromas and to prevent contractures in the armpit, or like in the hip area, as the surgery may be.
Ah, okay, okay. And then
Yes.
can a person, in terms of their movement, as they're sort of progressing through, could a person, even with lymphedema, be able to do things like lifting weights, and more advanced exercises? Or, for example, if a person was really active prior to surgery, are they able to get to maybe a higher level of activity if that's what they're accustomed to?
Absolutely, yes. Now,
Good.
that is a great question. And this question does come up all the time. Can I lift weights?
Hmm.
Um, so we want to remember, post surgically, like, you do not lift weights for, it's a surgical precaution. You do not lift weights for 4 to 6 weeks, depending on the type of surgery. So after which, obviously, your body is a little bit debilitated. So you can't just start lifting 8, 10 pounds right away.
Yeah.
So you want to increase your tolerance to lifting weight. As also, if you are a person, or if you are a patient who's more likely to develop lymphedema based on your diagnosis or based on your surgery, then it is best to go through your therapist and get like the proper exercises first, like, get fitted for a compression sleeve first before we start lifting weights. But all these dragon boat races and so on, they those women are breast cancer survivors. They are doing fantastic. And
Wonderful.
so in 2012, to add to this particular thing, in 2012 there was a person who had brought up an exercise protocol, and I actually have that whole protocol of how to do weightlifting. It's an entire like hour long protocol.
Wow.
Like, you start like with like little bit of weight and progress on to 10 pounds to progress on to actually weightlifting.
Wow.
It's called the PALS, Physical Activity and Lymphedema. The therapists nowadays do not do it, but I was trained way back when for this. So I basically will train a person for weightlifting if that is their goal. Hey,
That's
why not?
great. Yeah.
Lymphedema is not, it should not stop you from doing anything. Let me put it that way.
Oh, see, and I'm so glad you mentioned that, because this, I understand the concern, especially what I hear from our community, and a lot of that concern is, will it impede their daily living, their activities, the things that they like to do? And to hear you say that, I think is really reassuring to hear that the goal is so that it does not affect whatever a person wants to do, like, whatever they choose to enjoy in their life.
So the precautions that I do want to mention here is, it is extremely important to go through the proper channels. After your cancer surgery, it is very important to go through therapy. It
Okay.
is by far one of the most important things, because getting fitted for a compression sleeve, getting fitted for proper compression garments as need be, releasing scar tissue, because scar tissue, when it forms, it's a big impedance for lymph to move. And
Okay.
like, I actually have a patient right now who came in. She told me exercise makes my lymphedema worse. And
Okay.
my answer to her was like, you might be my only patient, so let's do an assessment. So come to assess this person. She has plenty of scar tissue built up because of radiation.
Okay.
So a therapist would then release that scar tissue, remove that impedance, and then, like, obviously, like, fit her for some kind of a compression garment so that the lymphedema keeps on moving.
Okay.
That's my plan of care for her. I mean, I don't know if
Wow.
she's on the call today, but that is my plan of care for her.
Wow.
But there are certain things that need to be assessed.
Yeah.
before, you go in for full-fledged exercise.
Yeah. That's
Unless
really
you're an athlete, then obviously you may hire a private therapist.
right. Lucky. Well, and you've mentioned compression garments a couple times. If a person has developed lymphedema or think they may be developing it, is it really, best to get properly fitted? Or could a person maybe be doing a detriment if they just decide to fit themselves or just to buy something that is compression? Talk about that a little bit.
So compression garments always have to be fitted.
Okay.
Always have to be fitted by a therapist.
Okay.
And I cannot stress that enough, because I see a lot of cases, people buying compression garments on Amazon.
Yeah.
And the problem with that is, you cannot just fit a person for compression garments. You have to have had some work with the lymphedema, like moving the lymphedema. The whole idea is building new channels for the lymph to move.
Right.
But if that was not done and a person just goes in and buys compression garments, they are going to form like not just a tourniquet kind of a thing, but also it may increase the lymphedema, the existing lymphedema. So
Wow.
like in our training, and there are so many garments, I would say there are at least there are about 12, 15 brands in the US. Within those brands there are hundreds of garments that you can actually assess a person for. So it's best to see a therapist who knows what is best for you.
Okay.
And in my practice, I've also seen some therapists prefer certain types of or certain brands of garments, which may not be the right thing for that person. So there's a lot of factors, what is the lifestyle of the patient? Is the patient living alone? Will the patient be able to put that garment on by themselves? A lot of factors that come into play when assessing for a compression garment. And I seriously do not think patients should try that by themselves.
Okay. Oh, that's really good to know. Okay.
Yeah.
Okay. Um, Another question submitted, a person says that they have had lymphedema in their arm, wrist, and hand. It's been very difficult to get out, and she feels her local therapists don't know what to do. She's used 2 different pumps, but she doesn't feel they've done much, but it hasn't necessarily made it worse, but nothing gets it out. Would you have any suggestions for this person?
So I wouldn't suggest anything based on the information that I have, because I would want to know more information. So if you don't mind, the person can email me some more information if they want, and I could answer that question in a much more specific manner.
Okay.
But to that, if the lymphedema has not moved, or if the lymphedema has not gotten better, my question is is that metastatic lymphedema? Are there other metastases that we are working on? Because in that case scenario, then what happens is that the lymph is actually on an overload from the other cancers that it has to deal with in our bodies. So the lymph is not going to move because it's on an overload, and the lymph nodes are already doing so much work that they cannot move what is already existing. So there's a maintenance plan that can come into picture, doing like a daily manual lymphatic drainage kind of a thing, versus a pump, because pumps do not work in this case scenario. Pumps are more of a maintenance kind of a thing, where when the lymph has moved and we want to suggest some kind of a maintenance plan for patients for home, then we would do a pump.
Okay. Okay.
Yeah, but
Okay.
I would need more information from that patient, whoever has sent that, and I would gladly be able to. I would like to help.
Perfect. Okay. Yeah. So hopefully that person is watching and we can share your contact information. You can always email me at nutrition@uniteforher.org and I will pass along Nipa's contact information very happily. Just a couple last questions before we wrap up. I had mentioned before I was chatting with a woman that has an ovarian cancer diagnosis and has had some surgery involving the pelvic area, involving some of those lower lymph nodes. And her concern was developing lymphedema in her lower limbs. She mentioned having a little bit of sensitivity to sodium and some water retention. Does that mean in that instance she may be developing lymphedema? Is that sort of swelling is one related to the other? Can you speak a little bit to that?
So depending on the type of surgery she's had, if she's had radiation, that is a big factor in determining whether there could be lymphedema or not. But surgery, abdominal surgery in itself, gives you a long-term swelling. Let's put it that way.
Okay.
It's necessarily not lymphedema. And
Mm-hmm.
if there weren't too many lymph nodes at that point removed from her, so chances of so if there was swelling in the abdomen, just
Mm-hmm.
post-surgical swelling in the abdomen, it's difficult for the lymph nodes in the groin to drain anything from her legs, unfortunately, because then,
Okay.
we have to work on the abdomen, because it's like osmotic pressure, the abdomen has to be cleared first
Yeah.
before anything else gets cleared. But
Okay.
we are talking about reversible lymphedemas. They're
Oh,
absolutely treatable. But again, if this patient has had radiation, it may be more of releasing that scar tissue that is developed, because the type of radiation they do these days, it's also very localized, but it does put spasms in the muscles. It puts spasms in the quadriceps. It puts spasms in the iliopsoas muscle. It
okay.
puts so oftentimes, if a patient tells me, I have off and on hip pain, but it's not a major concern, I will first assess their hip joint to see what is going on with their muscles, because that is a major issue with a lot of ovarian cancer patients. Their muscles do get affected, and
Yeah.
when muscles are affected and they're in spasm, they are not moving enough. So traditional physical therapy or traditional exercises actually are more beneficial than just manual lymphatic drainage.
Wow, that's really good to know. And Lisa had a question that you've mentioned before. How do you release scar tissue? So I think we can wrap up with this one. This is a really good question, Lisa, and I'd like to know as well. So how does a professional like yourself go about doing that?
So there are techniques they fall under the category of myofascial release. So I am certified myofascial release therapist, and a lot of us are certified in myofascial release therapy. So it is a manual technique. We actually feel the tissue, and oftentimes I will tell my patients, my hands will listen, and then I'll release. So I actually palpate that scar tissue, and I work gradually on increasing. One of the techniques is just if it is just scar tissue release, an incisional scar tissue release, it's pretty easy.
Hmm.
You very gently go zigzag on the scar, with just a little bit of lotion, and you can go in circles above the scar and in circles below the scar, and very gentle circles. So basically, what I'm trying to do is I'm trying to retrain the fibrotic tissue that's built inside. I'm trying to retrain it to go straight. So there was a nice pictorial of what scar tissue is like. So normal collagen fibers are straight like this,
Yeah.
and in when there's a cut, like an incisional cut, or you fall, fibrin, which is part of collagen,
Hmm.
goes zigzag like this. So there is an actual pictorial,
Yeah. Yeah.
how it
I've seen
lays.
pictures in
Yeah,
anatomy.
yeah,
That,
and how it lays.
yeah.
So with myofascial release, what we try to do is we try and straighten that collagen, and it
Oh,
works beautifully.
okay.
I love my scar release. I love releasing scars. The simple reason being, lymph moves faster when you release scars.
Wow. And is it something that a person would need to continuously do, or once that is released, they're generally pretty good to go?
So incisional scars, surgical incisions, they are pretty easy to release, and once released, they're good to go. Unfortunately, radiation-related fibrotic tissue and scar tissue is, radiation has genetically just modified everything now.
Okay.
So every few months, unfortunately, patients do have to come back to me, or
Okay.
sometimes I teach the patients what needs to be done to sort of maintain a normal tensile strength in their skin.
Yeah.
So with that restriction, constant feeling of restriction doesn't happen. So sometimes I train the patients what to do.
Okay.
But Lisa Ann, it's a myofascial release technique that a lot of therapists will do to release scars.
Really interesting. That's a really good question. Good. Okay, so we've had some really good questions. We've got some great participation through Facebook. Nipa, I want to thank you as we wrap up. And I think a great way to sort of finish this off, if you had to offer some tips to our audience on lymphedema in general, or just some initial steps a person can take if they're concerned about developing it, or they feel like they might be at the beginning stages, why don't you share with us just some things to leave us, some nuggets of information to leave us with?
Exercise, exercise. So exercise is the
Love that.
best way of dealing with lymphedema. Post-surgically, so Sloan Kettering actually starts their patients the very next day. Not
Wow.
all hospitals have a protocol of starting exercises right the next day, but
Wow.
Sloan Kettering does. And there's these simple exercises, like you stretch your arms up, you stand beside a wall, and I'm trying to get this right. And then climb your finger on the wall, okay? And you stop where there's pain the first day, okay? The next day, you try and reach a little bit higher, a little bit higher. So this is like the initial exercise that we have people do.
Okay.
And then we also have them do the pendulum. So you're basically leaning forward and swinging your arm.
Yeah.
Just basically swinging in a range of motion. Maybe this arm.
Just loosely swinging. Yeah.
Just loosely swinging it. So these couple of exercises will take you, they look very simple, but post-surgically, they can be a little bit hard. They can be actually very difficult. So exercise by far is nobody leaves me without exercises.
I love that.
Yeah, exercises by far, as also diet does play a big role, Erin, and you and I can relate to that.
Yeah.
So as much as possible, I'm not talking about antioxidants, I'm talking more of like your citrus family fruit and so on. Consume more of that. I think that's the best way of putting things within your, starting to control it.
Yeah.
Starting to control it yourself.
Yeah, I love that. I love that. Those are great things to finish up with. So Nipa, again, from the Unite for Her family, I just want to thank you for being here and being a resource. Again, if anyone is interested in reaching out to you, they can email me at nutrition@uniteforher.org. But again, the name of your practice, Bucks Cancer Rehab in Newtown Square, correct? Bucks County?
No, it's in Newtown.
Oh, Newtown.
Square.
Newtown, Pennsylvania. Yeah, they're in two
Newtown Square is in, I think, Montgomery County. Newtown is in Bucks County.
Okay, so don't listen to my geography. Listen to Nipa on where her practice is. But she's wonderful. She's happy to help anyone that reaches out. We'll definitely pass along your contact information. But once again, thank you so much for being here. Thank everyone for hopping on and sharing your questions. Be on the lookout for future events that we have coming up in September, future Ask the Experts and Speaker series. And we hope everyone stays safe and enjoy the rest of your week. Thanks again. Thanks, Nipa.
Thank you so much, guys.
Bye. Have a great day.
You too.